stream on YouTube. 1 second. We'll start, sir. Yes, good evening, everyone. Welcome to the Indian Arthroscopy webinar series. This is the third series of hip arthroscopy we have started, and we have got good response from all over the world. I thank Professor Soshi sir for being there with us for making this happen.
Okay, thank you very much. Good evening. My name is Toshi Uchida, along with one of the program chair of this webinar. Today's webinar is hip arthroscopic series number 3. Let's get started to perform hip arthroscopy. So I'm getting into the introduction here. So we are very excited to have a great program in front of you today. Special thanks to my friends who made this possible and spent this time. And let me introduce today's speakers. Number one, Dr. Shinichiro Takada. He's gonna talk about the safe setup and complication of hip arthroscopy. Number two, Dr. Yoichi Murata, anatomical consideration of hip arthroscopy. Number three, Dr. Ayan from India. He's gonna show his case presentation. We are entitled this webinar, hip arthroscopy series. Let's get started. Perform hip arthroscopy. To give the audience idea, we are taking a question from those who are participating in the live today through the webinar Q&A application and YouTube question box. And please type your question in the Q&A box, and it will be answered by our presentators. Please stay in tune. First speaker, Dr. Yoichi Murata, we're gonna speak about anatomical consideration of hip arthroscopy. Dr. Murata, please go ahead.
Thank you for the kind introduction, Dr. Juda. So I will share the slide. Can you see the slide?
Yes, we can see your slides and we can hear you clearly.
Yep. So my name is Yoichi Murata. So I'm working with Dr. Uchida and now practice the hip arthroscopy. So I'm talking about the anatomical consideration of hip arthroscopy. First, in diagnosing the cause of hip pain, there is a concept and approach that has been increasingly used in recent years called the anatomical layer concept. Layer 1 refers to the bone and cartilage inside the joint. Layer 2 refers to inner layers such as joint capsule and labrum. Layer 3 refers to the contractile layer, which includes muscle tissue and attaching tendons. And layer 4 refers to the nerves running between the muscle around the hip joint. In this presentation, I will explain layer 2, hip labrum and joint capsule, which is often treated with hip arthroscopy. I will explain the role of the hip labrum. The hip labrum attaches to the acetabular limb as layer 2, and it has a sealing effect that traps synovial fluid to form a smooth joint surface. Additionally, it provides a suction seal effect towards the femoral head. These effects stabilize the hip joint and also serve as a shock absorber. Let's see the biomechanics study of hip labrum. The femur was extended at a velocity of 0.5 mm per second from a compression of 500 Newton. The graph shows the force and pressure curves of representative test specimens over time. A sudden decrease in both tensile force and negative pressure was observed at the same time, it indicating the rupture of the suction sheath. The objective of treatment for hip labral injury is to regain the suction shear effect lost due to labral damage and hip joint stability. I will describe the local anatomy of the hip labrum. The hip labrum is fibrocartilaginous tissue that attaches circumferentially to the rim of the acetabulum, and inferiorly it is connected to the transverse ligament. When the cross-sectional view is enlarged, it appears as shown in the diagram on the right, attaching to the rim of the acetabulum and protruding outward. Studies measuring the width and thickness of the hip labrum have revealed that the labrum is thicker in the anterior and superior regions, while it becomes wider and more flattened in the inferior region. This is a cross-sectional view of the hip labrum captured with an optical microscope. It is separated from the articular cartilage of the joint surface at the location indicated by the arrow. It consists of two different tissues. The inner part is composed of fibrocartilage, while the outer part is made up of dense connective tissue. Within the inner fibrocartilage, chondrocytes are present, while fibroblasts are observed in the peripheral dense connective tissue. This is the image of the hip labrum captured with an electron microscope. The superficial layer, approximately 10 micrometer deep from the articular surface, consists of a mesh-like structure composed of thin collagen fibers with a diameter of about 30 nanometer. The underlying layer, 200 to 300 micrometer deep, contains packed bundles of collagen fibers with diameter ranging 100 to 130 nanometer, oriented in different directions along the longitudinal axis. The remaining majority consists of dense fibrous tissue with collagen fibers running in a circular pattern. This demonstrates immunohistochemical staining of the extracellular matrix. The majority of collagen fibers are stained with antibodies against type 1 collagen. Additionally, immunostaining for type 2 collagen showed positivity in the pericellular matrix of the fibrocartilage cells. The blood supply to the hip labrum primarily involves the superior gluteal artery, inferior gluteal artery, and obturator artery. Radial branches from the circumferential vascular ring of the acetabulum enters the joint capsule from the bone surface and penetrates through the synovium of the labrum joint capsule site. Posteriorly, where the blood flow is more abundant, immunostaining for laminin, a component of the vascular basement membranes, detected blood vessels only in the outer one-third of the labrum. In a study utilizing cadavers with 12 hip joints, the blood flow distribution of the labrum was analyzed by dividing it into 4 locations. In each location, it was found that the blood flow on the joint capsule side was significantly greater than on the articular surface side, with a distribution of blood flow approximately twice. Similarly, various nerve endings are present on the joint capsule side. Although they exist in all areas of the acetabulum limb, they are suggested to be more abundant in the superior and anterior regions, particularly concentrating at the chondrolateral junction. Injury at this site can cause pain. As a method of anatomical representation of the hip joint, quadral notation is often used, dividing it into anterior, posterior, superior, and inferior quadrant. Additionally, with the advancement of hip arthroscopy, there is a trend toward using a clock face representation to indicate the detailed position within the acetabulum, with the acetabulum fossa being considered at 6 o'clock. The hip joint capsule ligament is composed of separate bands that reinforce the joint capsule. Anteriorly, there are the iliofemoral ligament and the pubofemoral ligament, while the posteriorly, there are the ischiofemoral ligament and zona ocularis. The iliofemoral ligament, which is the strongest among the capsular ligaments, contributes to the stability of the hip joint as a major static stabilizer by resisting anterior translation and external rotation of the hip joint. The femoral and obturator nerves and the nerve to the quadratus femoris were found to consistently supply articular branches to both the anterior and posterior capsule of the hip joint. The anterior capsule primarily supplied by the femoral and obturator nerves, and the superior labrum appear to be the primary pain generators of the hip joint, given their higher density of nociceptors and mechanoreceptors. A systematic review summarizing biomechanical studies on the hip joint capsule has concluded that addressing the capsule is so very important for preventing microinstability. In our meta-analysis, we found that repairing the hip joint capsule led to improved patient-reported outcome measures and lower conversion rate to total hip arthroplasty. Additionally, we performed the cadaver study compared with between the native head and 5 cm capsule cut. After that, we repaired the various suture pattern. And shoeless, double shoeless, and Quebec stitch rider were superior to other suturing methods. And none of the suturing methods were able to improve stability to the native level. So now we are using the periportal capsulotomy. This is the air portal and the labor repair and cam osteoplasty using the periportal capsulotomy. Finally, capsule repair with mini tape. We found birth at 7 days after surgery is significantly superior in periportal than interportal. Surgery to work without canes is significantly shorter in periportal group than interportal group. Conclusion: the hip labrum is a fibrocartilaginous tissue that attaches circumferentially to the rim of the acetabulum. It possesses the sealing and suction effects, contributing to hip joint stability. The blood flow on the joint capsule side is better than on the articular surface side. The hip joint capsule is composed of several capsular ligaments, with the iliofemoral ligament contributing the most to hip joint stability. It is difficult to restore to the native state once the iliofemoral ligament is incised. So it is important to limit the incision to the minimum. So now we are using the periportal. So thank you for your attention.
Okay, thank you. Thank you very much for Dr. Muratar.
Thank you.
Any question from audience? So Dr. Muratar, can you show us how do you repair a Quebec City slider or shoelace suture? Yeah.
So
maybe
thank you for,
many Indian doctors are seems to be a beginner. So can you explain a little bit more detail?
Thank you. Thank you for your question. So now we are I mentioned that, so we are using the periportal capsulotomy. So I think it's a very small capsule cut. So now we are using the Quebec slider. We believe that it is enough to prevent the micro instability. However, so in the case of a big cam or something, so more bigger capsular incision, so we may have to use the shoeless technique, double shoeless technique. I think it depends on the length of the capsule cut. If we use the periportal capsulotomy, Quebec sterilizer is very enough.
Okay. Naresh
Sir,
or
can I ask one question?
Mm?
you go ahead.
Uh, Dr. Yoichi,
Mhm.
uh, which case, in which case we can open or don't close the capsule, or we have to close the capsule in all the surgeries?
Uh, s- you mean we have to close the capsule in all case?
Yes, yes.
I think so.
Okay,
Especially so, map portal is more important to close the
okay,
capsule. So
okay,
because the iliofemoral ligament anterior side.
okay. Uh,
Naresh,
Sir, yes,
Naresh,
sir.
you mean that do we have to repair the capsule even though the periportal capsulotomy approach is right?
Yes, sir. Yes, sir.
Yeah, yeah. Dr. Dr. Alan Chang from University of California, San Francisco devised this technique, periportal capsulotomy approaches. The author recommended no capsular repair. They don't have to repair the capsule, but
Okay,
they repair the capsule only for capsular laxity problems
okay.
or borderline hip dysplasia. But
Mm,
for in Japanese patient, I think the hip instability or the capsular laxities in the patient is more prevalent in the US. And that's
okay,
why we try to repair the capsule only a map portal because map for MA mid anterior portal mid anterior portal is located usually in the iliofemoral ligament.
yes,
So that's why, yeah, the real iliofemoral ligament, the Dr. Yuichi mentioned about the iliofemoral ligament is the most important to stabilize the joint. That's why mid and border, even though the periportal approaches, we usually routinely repair the capsule.
thank you, sir.
You're welcome.
Thank you.
Okay.
Yeah,
Maybe audience want to ask maybe considering what they want to ask a question. So we are move on to the next speaker. Because if you want to ask a question later on, you can type on the YouTube question box. Okay. Uh, Dr. Takada, are you ready?
Yes. Okay.
Okay.
Yep.
Dr. Takada will talk about uh, set up a complication of hip arthroscopy. Please go ahead.
Yeah, thank you for your introduction, Dr. Chida. Let me share the slide. Can you see it?
Yes.
Okay. Thank you for inviting me to this webinar, and I'm Shinjiro Takada from Thomas Hospital of UOEH Japan. I'm talking about safe setup and complication regarding hip arthroscopy. At first, why safe setup needed? The purpose of the safe setup is to promote surgery more efficiently and to minimize complications and to minimize invasiveness to patients and finally to improve clinical outcomes. There are some large systematic and multi-center studies regarding complication rate related arthroscopy. The reported complication rates were about 4 to 8%. I will introduce you one of these reviews. Dr. Chris Shenno reviewed complication regarding arthroscopy in 92 studies and more than 600. The reported major complication was 0.58% and minor complication was 7.5%. The reported major complications such as deep infection, skin injury, lung embolism, intra-abdominal or intrathoracic extravasation, and inferior damage, vascular necrosis, and femoral neck fracture, and dislocation, and either death due to fluid extravasation. We also reported 7.5% had minor complications such as iatrogenic control and labral injury, nerve injury, superficial infection, hypothermia, deep vein thrombosis, and broken instrument and ectopic ossification. Iatrogenic injury and nerve injury were the two most common minor complications, and they concluded that minor complication is directly related to the learning curve of hip arthroscopy. There are three major causes of complications during hip arthroscopy. First, positioning and traction, and second, joint entry and access, and third, fluid management. At first, complications regarding positioning and traction. We usually perform hip arthroscopy in supine position. To get good visualization during surgery, secure foot fixation to the boots and sufficient traction of the hip joint is necessary during preoperative preparation. However, overcompression and overtraction can cause skin injury and also nerve injury, especially here and the perineal area, also related to the traction. To prevent skin injury, we routinely use the foot pad and additionally put the cushion pad under the heel and the dorsal side ankle. And then foot was fixed on the boots. And also counter-traction with using perineal post can cause nerve injury. In this area, there is a branch of posterior femoral cutaneous nerve and a pudendal nerve. How was the nerve injuries underreported? A prospective study from Dr. Performic looked at nerve dysfunction after hip arthroscopy of 52 patients. 6% reported nerve dysfunction 1 week post-op and 18% reported nerve dysfunction at 1 year post-op. Another prospective study from Dr. Ivan Wang sent a questionnaire to patients, and he found a rate of 37% operative number. And also, Dr. Mei Zhang reported 25% incidence of the short-term urologic or sexual dysfunction related to post-use. Additionally, he reported 1.5% incidence of pudendal nerve injury on retrospective studies. For that reason, he prospectively looked at 1,000 hips with postural destruction. He demonstrated no groin-related complication with the postural technique. So clearly, the perineal post is a concern for groin-related injuries and may be avoidable by using postural. So we always use this postural traction system before the impact to avoid complications regarding traction. Now I will show you the actual setup. Head down to resist the distal traction force. And then for traction. Really literally. And then operative side traction is caused. To prevent the foot further off during surgery, make sure the gap between the foot and the sole within 1 finger. And then adduction and extension. Hip adduction and extension with retraction. We check the arthroscopy and confirm sufficient traction, and then release the traction. Next, remove the pelion post, and then traction with outside. Contralateral start first. Relative side traction. Finally, we confirm sufficient traction by fluoroscopy. During this procedure, counter support in the pelvis is necessary. Final check. We check securely seated the impact. The gap between the foot and the sole between one. Next is the joint entry and complications and how to prevent these complications. Let's line show a part of complications related to joint entry and access. Lateral femoral cutaneous nerve injury can caused by joint entry, and iatrogenic condylar injury is the breakage. Here is the filters using in hip arthroscopy. We usually create these 2 or 3 portals. Anterolateral portal and the mid-anterolateral portal called MAP is necessary, and sometimes we create proximal and mid-anterior portal called PMAP. The anterior portal pass in close proximity to a small terminal branch of the ascending lateral femoral cutaneous nerve. Greatest risk still comes from the proximity of the anterior portal to the lateral femoral cutaneous nerve. A more lateral location may provide some protective benefit. Portal placement. First, palpate the outline of greater trochanter and the anterior superior iliac spine, ASIS. First anterolateral portal was created at 1 cm superior and 2 cm anterior to greater trochanter. Draw line straight down from ASIS to the patella, and then draw the perpendicular line from ALP. Draw a parallel line to the first line through the middle of this line. And second portal, mid-anterior portal map is made. Next, we introduce the opening to the hip joint. In this procedure, not penetrate labrum while introducing needle. We always introduce air for air arthrogram that make it possible to identify labral concentration. And we have experienced some cases with iatrogenic cartilage injury as well as labral operation. To prevent iatrogenic damage, we have to introduce cannula toward to the proximal space, not toward to humeral head. Next, about fluid management. Irrigation during hip arthroscopy sometimes causes extravasation. There are several case reports demonstrating fatal adverse effect. We have to care of these warning signs of arthroscopic fluid extravasation. Inability to distend joint, increasing fluid requirement to maintain joint distension. Frequent cutoff of pump irrigation system, abdominal and side distension, and acute hypothermia. For arthroscopic irrigation pump should be managed between 30 to 15 mmHg. Patient blood pressure should be managed between 80 to 90 mmHg. Immediate coagulation if bleeding, thermal shrinkage if capsule distension. And the most important thing, don't be panicked, calm down, and never give up. Conclusion. I talked about safe setup and education regarding hip arthroscopy surgery. Safe setup is necessary for good surgery. Before everything else, getting ready is the secret of success. At last, we really appreciate to Dr. Naresh and Dr. Vikas for inviting us to such a great conference. We spent a precious time in Japan, and we are looking forward to working with you again. Thank you.
Thank you for a great talk. Any question from audience? Dr. Naresh?
Sir, my question is, what is the difference between a standard traction table if you are using for hip arthroscopy or perennial without perennial post traction table?
I'm sorry. Your question cannot hear. One more, please.
What
Yeah.
is the difference between perennial post and postless pink pad? What is the difference?
The difference between the perennial post and the postless
Postless, yes.
big pad.
Yeah. What is the
I
difference?
mean, the big difference is there's a post or not. Yeah,
Yeah.
of course.
In terms of complication, in
Oh,
terms of
complications.
yeah.
Okay. The complication and the advantage of a postless system is the avoiding the complication regarding the compression to the perineal area, including the nerve injury or the skin injury. That is the best different things.
And also, what is the disadvantage of postless? Disadvantage of postless.
Postless system, the
Postless one.
advantage is sometimes the insufficient traction, and in that case, the surgery becomes more difficult. So
Okay.
we have to check the sufficient traction always. Yeah, that is a very important thing, I think.
Okay. And also
Yeah.
cost, right? Cost. The
More
postless
cost.
pink pad cost $500 bucks.
Okay.
Yeah.
I have a quick question. Hello.
Please go ahead.
Sir, Dr.
Yeah,
Alan,
Yeah.
sir, please go ahead.
So we all know that hip arthroscopy, it's also related. The traction time turns out to be important. So what is the optimal traction time that we can assume is safe for a patient?
Thank you for your question. We think the safe traction time is within the 60 minutes. Yeah, if
Okay.
the surgery that prolonged more than 60 minutes, uh, you have to release the traction, and then again traction again.
So how much
Okay.
rest would you give to the patient between reapplication of traction when you let go the traction?
No, sorry.
So say if a surgery is lasting more than an hour. Hello.
Yeah. If the
Yeah.
surgery prolonged over,
So and you let go the traction. So after how much rest time can you go back and reapply the traction?
yeah, I think it is enough to about 5 to 10 minutes. Yeah, and then you traction again.
Because for people who are starting hip arthroscopy, that turns out to be important, because if you're trying to do anything meaningful, trying to do something like a labral repair or a cam, so most of the cam resection you do without the traction, but for the labrum repair, if you are not able to finish, so that's a good take home point today.
Yeah.
Yes.
Okay. The
Thank you. Thank
traction is
you.
needed in the interarticular procedure, and if the surgery prolonged over the 1 hour, you combine to the extra articular procedure, and then go back to interarticular procedure.
Okay,
Yeah.
that's a good idea. Yeah.
Dr. Takada, there is a question in YouTube. Do you perform capsular reconstruction, and are the grafts able to replicate the flexibility and thickness of the capsule.
Labrum reconstruction case.
Yes, yes. Capsular reconstruction. Do you
Oh,
perform?
in capsular reconstruction case?
Yes. And the
So,
grafts are able to replicate flexibility and thickness.
graft thickness.
We don't understand your
Yeah.
question. So capsular reconstruction, or usually use when we perform the capsular reconstruction for only revision cases.
Okay.
Yeah. Because sometimes second look or third look hip arthroscopic surgery for the capsular capsulotomy leftover or applicate capsular but no tearing and just open it. So we usually use the IT band graft,
Okay.
iliotibial band graft, and then two hold graft, and applicate suture it, and then uh, place the suture anchor at the acetabulum side, and then outside the body, and then suture the graft, and then slide it into the intra-articular space, and then suture the proximal side of the graft, and then
Okay.
repair the graft and the distal end of the capsule.
Okay.
Yeah,
Are there really flexible, and how much strong is the
flexible means
construct?
flexible means unstable hip
Ah,
instability. Do you mean? Yeah,
yes, yes.
yes. Usually, distal end of the capsule is thicker than proximal end of the capsule. So I think
Okay.
I in our experience, it's good enough to good hearing. Okay.
Okay, sir. Okay.
Okay.
Thank you.
Okay. So let's move on to the next speaker. Dr. Yang, are you ready?
Yes, I'm ready, sir.
Okay. Please.
So let me start sharing my screen. So I'm about to show a case of a labral repair, and where we tried to do a rim recession and finally did a cam excision for this patient. So
Sir,
let me.
Dr. Ayam, sir, please speak little louder. We are not able to hear.
Okay, is it
Keep.
audible better
Yeah,
now?
yeah. Better, better, sir.
Okay,
Yes,
okay,
better.
okay. Uh, so this is a case of a 29-year-old male who presented to me with 8 months history of pain on squatting. Uh, so after squatting, when he would walk, it would hurt more, and this problem was progressively getting worse. For the last 2 months, even bending forward was causing pain in the right groin. So we did an examination of this patient. His gait was okay. Uh, the range of motion was pretty much normal. Uh, there was some pain when we did an internal rotation, 90-degree flexion, but the rest of the range of motion was pretty normal. He had a positive impingement sign, and from the clinical examination, we examined his hip flexors with resisted straight leg rising, and that was all okay. So the only positive finding in the examination was a positive impingement sign. So as we are trying to elicit the impingement sign, he had a wincing face when we did that. At the same time, when he comes to us, we get a hip X-ray, and apparently a normal hip X-ray, both AP and lateral, looked okay. The very fact that he was having impingement. Uh, so yeah, at this stage, let me put this question to Dr. Uchida. So if you have a patient who has a positive impingement, would you what would be your plan of action at the first visit when you see such?
Professor,
Yeah. So taking history and the physical examination is more important for assess the patient symptom. And then plain X-ray is a really important variable to assess impingement or dysplastic hips. Is that the answer is your questions?
Oh, no, I was asking if you have a patient who has a positive impingement test and the rest of the examination is normal. So what would be your first step? Would you want to get an MRI or just see if NSAIDs or physical therapy are helping him at the first visit?
Usually I let them go to physiotherapy first, and then
Okay.
how it works. And if still persistent pain, I try to examine a lumbar spine and SI joint problems, because SI joint problem is a high frequently associated with hip pain. That's why exam SI joint and the lumbar spine first.
So for this patient, I gave him a trial with NSAIDs for 7 days and sent him for physical therapy, asked some restriction with the movement. And hello.
yes, sir. Yes, sir. Please go ahead, sir. We are hearing.
Yeah. So that did not help him with the pain. So what happens is he comes back to me after 7 days, and he still has that pain. So at this time, he also had a positive impingement again. So we thought of giving him ultrasound guided prednisolone injection and see how the pain works. With the injection, he reported significant improvement, and 3 weeks later, he comes back with the same pain. So at this time, we decide to get a MRI, and this is his section of the MRI. So this is the coronal cut, and on the right side, if you see, I'm trying to enlarge the images. So here we can clearly see that the right side labrum is peeled off, and this is attached downwards. The left side, it has a firm, good attachment to the rim, but the right side is virtually peeled down, and it's almost uh, obliterating even the joint space. So this is a axial cut. Here also we can clearly see that the left one has a very good attachment, and on the right side this is an inversion of the labrum, and it's like virtually pointing downwards now. So the treatment plan at this stage was we decided to go ahead with a hip scope, see if a rim recession was required, but yes, definitely doing some labral repair. And most of the cases that I've been doing here, so they tend to come with a lot of degeneration. So these are ignored and missed cases who have had this problem for a long time. So getting a good labrum to repair has always been a problem here. So labral debridement was also one on the agendas, and then the plan was to do a cam excision femoral osteoplasty. So during the surgery, this is the kind of distraction that we got. We go in with the needle and then with the dilator in the joint, then with a switching stick, and then this is the first view that we have on the left corner. So here we see that the labrum is pretty degenerated. It's a lot of fibrillation, and the structure looks like pretty beat up. Uh, Even all the 3 images we see, it's not a good quality labrum. Apart from that, he had intense synovitis. So as you see, the synovium was very inflamed from the ongoing inflammation for a very long time. Even a steroid injection did not help with the synovitis to this patient. So we come in with the mid anterior portal, and then we start clearing the space, because in these cases where you have a lot of synovitis, it's so difficult working in the hip space, getting a visualization. That's always a problem, and we tend to struggle with that. So this is the first time, like after clearing and doing a capsulotomy, we got a good image. But as you see, the labrum here. So this is the we start actually at this point. We start taking down the labrum. So the plan was to detach the labrum, make a clear, healthy bed, and try and repair back the labrum to the rim. So this is the rim marked in red. That's the acetabular rim, and this part is the labrum, which appears very unhealthy. It's not a very good labrum to work with. There's some focal calcification also in the labrum, uh, and then we start like receding, doing a what you call the takedown of the labrum. So as we can see, we have done a generous takedown. But despite that, when we are assessing the mobility of the labrum, it's degenerated. It's not very flexible, not amenable to good repair. So at this time, we decide that unless we remove some bit of the rim, it will be very difficult bringing this labrum back to the bone, because it has been there, torn and almost dislocated for a pretty long time. So we start shaving the rim with a burr, and after closely working there, we were able to like get a good almost 4 or 5 millimeters of the rim down, and then we assess the mobility, which by this time the mobility had improved. So we come in with our first anchor on the rim, making sure that we are not penetrating the joint, and then as you can see, so seeing from this side, we can see we are unable to see inside the joint, because this whole labrum is like covering that entrance like a veil. It's like a draping sheet, which is not giving us a visualization of the inside of the joint. And then after the repair, once we are able to put in 3 anchors and bring this labrum back on the rim, we get a pretty good visualization of the hip joint, and we see that we have been able to restore some bit of uh, preserve labral tissue, some bit of labral tissue, and we attach it back. So these are the final images there. And then we work on the cam part of the surgery. So this is a big cam bump, which was not very clearly visible on an X-ray and not even on an MRI, but examination wise, we can see it's a good big size bump. And we take that down with a burr, doing a good cam excision. So rehab wise, so I usually end up taking much more time than a normal, like well-trained person would do. So most of these patients would need epidural in my hands for almost 48 hours for pain relief. Day two, we start doing toe touch weight bearing and sitting up in bed for 2 days to 3 weeks. They are on 50% weight bearing. 3 to 6 weeks, we let them be at full weight with restriction of flexion beyond 90. And at 6 weeks, we let them walk normally. We allow full spectrum of activities by 20 week onwards. So this is the same patient almost 1.5 years out, and he's able to, like in India and in this part of the country, it's very important to be able to sit down, squat, and sit with crossed legs. So he's been able to do that perfectly without pain, and squat and get up, and he has been a very happy patient for me. Thank you.
Okay, thank you for nice talk for Dr. Ayan. Okay, any question from audience? Okay, my question is, I have a question regarding
Yes, sir.
your cases.
Yes, sir.
Your brain X-ray showing the patient looks over coverage of a socket. So how was lateral set edge angle?
Hello, sir.
Lateral set edge angle. What is the lateral set edge angle of this patient, right side? center edge angle, CE angle, CE angle of this patient.
Oh, the CE angle.
Yeah,
Uh,
C.
Yes.
mm,
Maybe.
no, I actually did not measure the CE angle in this case.
Okay.
So I would
Okay.
have done it, but I failed to take note of that.
But this degenerative labrum looks like irreparable labrum, right? So
Okay.
so our study is looking at what is the predictor of an unsalvageable labrum. That means irreparable labrum. The cases, the predictor of irreparable labrum is lateral center edge angle greater than 38 degrees. And
Okay.
anterior center edge angle, we call it also VCA angle, and the horse profile view is greater than 39 degrees.
Okay.
And age older than 42 years old. So those patients is a higher risk of unrepairable, unsalvageable labrum. So, so we have to, we, I will strongly recommend we carefully measure the lateral center angle
Right.
and also VCA angle, and then maybe pincer type impingement can cause severely damage
Of the labrum.
their
Right.
labrum. So yeah, so those cases we usually perform the labrum reconstruction.
Okay.
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 Can I ask?
Any other
Any
question?
other question?
Can I ask?
Yeah, please.
Yeah.
Sir,
Yes.
one more question.
Yeah, I just wanted to ask.
Sir, 1 second. Someone.
Can
Hello?
you stop? Okay, Ayan, can you stop the slide?
Yes, I'll do.
Yeah. Okay, Dr. Nihar.
Yes, sir. Good evening. So I wanted to ask for a beginner in hip arthroscopy, which is the best case to start with?
Dr. Ayan.
Yes. So I think.
Professor,
So
are you able to hear me?
yeah. So Dr. Neha, yes, that's a very pertinent question. So typically, when you train in the West, you'll end up seeing so many good cases, like having a minimal labral tear, or these cases getting diagnosed very early. But most of the patients that I've like after my training when I moved back to India, so I've been like seriously looking for cases, and I bought a hip arthroscope set for the same to be able to try and do as many cases as possible. But the real problem is picking them up early. So most of these patients, they have an athletic background if you really want to pick them early, because if you don't pick them early, they get like lots of labral calcification, fibrosis. And I've done cases where the whole labrum is calcified. So these patients in the 39 or 40, as sir was saying, so ending up with and those are not very good cases to start. So I think a good case to start with is trying to get used to the hip arthroscopy, like like a joint lavage case, or taking a synovial biopsy where you can little bit spin around in the hip and spend some time trying to do things, and not take up cases where you have to do something meaningful. So not taking a impingement case early on in the starting hip arthroscopy.
Thank you.
Okay.
Thank you. Any question? Okay, thank you very much for Dr.
Yes,
Ayan.
sir.
Yeah. Okay.
Thank you, sir.
Yeah. Thank you for your time.
Sir, one more
Sunrise?
question. Sir, yes,
Yeah.
sir. One more question in the YouTube box. Dr. Santosh is asking, uh, how much did you resect for cam lesion?
Okay. So that's a very important question, I would say, because assessment of resection of cam is a difficult thing. So on the table, you want and go as far as, I would say, like 1 o'clock position, and then you have to rotate the hips both in 30 to 35 degrees of flexion and even in extension. So the proximal extent has to be, I would say, in 30-degree flexion, the head should disappear under the acetabulum. And that is my cutoff. That's a proximal extent of resection. The lateral is like you try to rotate 20-30 degrees and get every corner. So don't dig in deep. Don't make it very deep so that you are weakening the hip. But it's more of a eyeballing, I would say. There is a software by Smith and Nephew which actually tells you at what point how much millimeters. But that is for people who are doing these cases so regularly. For us, I think it's more of like seeing the impingement during the surgery and
Right, sir.
Yeah,
Sir,
how
one more question.
how to perform camera resection is I think it's a more challenging approaches. So next maybe next series, the next month, I think we can discuss the camera
Yes, sir.
plus 100. Yeah. Next to
Okay, sir.
yeah. Okay.
Sir, one more question by Dr. Ajay Chinchole. How much traction is to apply? Which parameters for applying traction?
So who can answer?
Professor, you can answer.
I think you're the best person to answer that.
Okay, one more.
Sir,
Again?
how much traction to apply while doing a hip arthroscopy? Are there any parameters for
Oh,
that?
it's a great question. So now we don't have any parameters for the traction. Only we just assess
Okay.
only measure how much wider space in the
Okay.
under fluoroscopy. So usually there's a paper showing how much traction is like maybe 30 pounds, 30 to 40 pounds in the traction power. But I'm not sure how much traction in the Japanese patient. So
Okay.
we have to investigate how much traction.
Right.
Yeah.
We have to see in Indian patients as well.
Yeah. Okay.
Right, sir. Thank you.
Okay. Thank you
Yes.
very much for participating in this webinar. Okay, we are looking forward to seeing you in the next month.
Yes, sir.
So
Thank
please
you.
end up to time. It's time to end up this webinar.
Yeah.
Yeah.
Thank you. Thank
Okay.
you very much, Professor Soshi Uchida,
Thank you
Dr.
very much.
Yoji, Dr. Takada, Dr. Ayan sir, Dr. Rohit sir, for being there for the conference and making this webinar a wonderful success. Thank you and good night. Bye.
Good night.
Bye.
Thank
Thank
you.
you.
Bye.
Good night.